here, and I'm just going to start it. So I'm a new faculty at the Department of Biomedical Engineering. I started about 2 years ago. And then before that, I was at the Wellman Center for Photomedicine. So most of what I'm going to show you now was done at the Wellman Center. And what we're doing now, continuing that project, is the analysis of what we collected over there. So I'm going to start just with the very basics of wound healing. So here what I have is a cartoon of the wound healing stages. So what happens when your skin is injured and then you have a full thickness injury. So you can see that there's four big stages, but the one I want you to pay attention to is that the healing in the second, from the top to the bottom, the second one, you can see that there is a barrier closure coming from the edge of the wound towards the center. So that's what is called epithelialization, and that's migration from keratinocytes to close the wound and create a barrier. Okay. So the motivation for this project is to try to help or guide the management of wounds. So what I'm showing you here is a chronic wound. So chronic wounds are very complex wounds, which they have a lot of comorbidities, and there's many reasons of why these wounds just don't heal. So traditionally what happens is you would go to a wound clinic, then a clinician would try something, and then the clinician would try to guess if the epithelium or the wound is closing, looking at the edges, and based on the clinician assessment would do an intervention or just continue with the treatment. The problem is that it's all based on experience and it's very subjective. So this is an ask actually from clinicians, like it would be great if they could tell if the wound margins are actually closing the wound. So this is the motivation for this project. And this is a big problem here and everywhere else in the world. There's a lot of chronic wounds, and it's just going to get bigger because the population is getting bigger and we're just living longer. So it's a very relevant problem. So this is about fluorescence. So probably this audience is very familiar with fluorescence, but just as a reminder, you have a molecule at a ground state. That molecule receives a photon, and then that molecule gives that photon, that energy that was gained, it gives it back as another photon, which is the fluorescence photon. So the point of this slide is like just to keep in mind that some molecules are fluorophores, but not all molecules are fluorophores. What that means is that you know which molecule is a fluorophore, and you understand the function of that molecule within the biology, then you have a very sensitive measurement because all the other molecules are going to be silent in terms of fluorescence. So this is just reinforcing that. So this is called electronic transitions, and then the question is, if you know the source of these transitions, or if you know these molecules, how can you use them for therapy or for treatment, or how can you use them in medicine? So in this case, the focus is the skin. So what you see here is a cartoon of the skin. You see at the top the epithelium, and you see a hair follicle. The skin is the largest organ in the body, and it's a fantastic organ because it's about 2 millimeters thick, but it has a lot of functionality. It is because of your skin that you can feel pain, you can feel heat, you can feel the sensation of touch. You sweat when you're hot. There's sebaceous glands, so it's a lot of regulation, a lot of going on in the skin. And the skin happens to have molecules which fluoresce. And these two Greeks, Nick Collias and Apostolos Doukas, they mapped them out based on a bunch of experiments. And that, if you're interested, you can read the paper in the Journal of Investigative Dermatology. But the bottom line is that they realized that the epidermis, there is a source of fluorescence. When you shine light at 295 nanometers, you get back light at 345 nanometers. And that fluorescence is ascribed to tryptophan. Then at the dermis, there are also other fluorophores. There's tryptophan as well. There's collagen, and it's the crosslinks that fluoresce. You think of collagen as fibers that, like a basket, if you will, and then just woven. And that crosslink is the one that fluoresces. And there are two types of crosslinks, pepsin digestible and collagenous digestible. And the other one that fluoresces is elastin. So the bottom line of this is that you could trace those signals because you know where they're coming from, and perhaps you can tell something about the skin. And in this case, we're going to focus on the top, on the epidermis, and just look at the tryptophan fluorescence at 295 nanometers. So we just built a very simple system. This is what is called one photon fluorescence. So you can see we have a UV sensitive CCD camera illuminating at LEDs at a specific wavelength. And we just have a filter in front of the camera, just collecting the photons from the fluorescence. It's a handheld. You can see it right there. There are two medical students holding it, and then you see the two engineers that made this prototype. So with this prototype, we carried out a study in animals. This is a preclinical study, and we used a rat, and we used two parts of the rat. We used the tail and the back. The reason for using the tail is because the tail of the rat heals by epithelialization, just like we do humans. If you use the back of the rat or use a pig, they heal by shrinking. That means that you can make a big hole in a pig, pigs don't scar, and they just disappear the wound. So the tail was a better model for what we were studying. So today I'm just going to show you results about the epithelialization of the tail. So here, what you see is a full thickness wound. So pretty much we just made a cut and we removed the entire skin of the rat tail. And you can see it healing at day 0, 7, 14, 21, 28, and 35. And then what you can see here is that obviously it's very obvious that it's closed at day 28 and at day 35. But the question is, did the wound close earlier? And you are just not able to see it. You're just not able to tell. So this is the fluorescence at 295 nanometers. So what you see here is like the green. Those are cells which are at a higher proliferation state. And these are keratinocytes coming from the edges and then just starting to migrate into the wound. So you can see that by day 14 is almost closed, but not quite. And by day 21, it is completely closed. Now, the standard in medicine is histology. So we did histology just to compare, to talk about results. And you can see at day 7, there's the wound. And then there's a little new epidermis, which just corroborates with day 7 the fluorescence. And then by day 14, the same thing. There's more new epidermis, but you still have a missing at the center. There's still a wound. And then by day 21, there's completely covered by a new epidermis. And so the other thing that is very common to do in this type of research is immunostaining. So we look at Ki67. So pretty much those histology, we just stain for a marker of proliferation, which is Ki67. And those are the little arrows. The arrows are pointing at purple dots. So that's Ki67 marker. And you can see the same thing. At day 7, you have some. At day 14, you have many. And then eventually, there is less and less fluorescence. Just there's a correlation between the fluorescence and the Ki67, not only in the number of Ki67 cells, but also on the location of the wound. It's too small to tell, but then pretty much we were looking at Ki67 of the middle of the wound, the edge of the wound. And so the take-home message, and then I forgot. So we had a chance to test this in a patient. So this study was not meant for the camera. It's a different study, and we just took the opportunity. So you can think of this as a safety study. Here, what I have is a patient who had 2 benign cancers, basal cell carcinoma. So in the one at the left, the patient is receiving a treatment, and the one on the right is the control. So there's no intervention there. So what we did, we just took images, which are hard to see. And I don't have a pointer. Well, that would be good if we can just. Yeah, that's a little bit better. So if you see the treated, you can see the treated at the first image at the top left. There is a ring of fluorescence, and then the center of the wound, there's some fluorescence, but there is less. And then when you keep going down in the treated, you can see that there is fluorescence covering the wound, so that's the wound closed. And then when you look at the untreated, pretty much you can see a ring of fluorescence not closing because that wound was left untreated. So what this just showing is just corroborating like this fluorescence is it's functional imaging. So it's just telling you that the keratinocytes are there, but then not moving in. And again, this was not designed to test the camera, but just an opportunity that we took. But the good thing would be to see what happens between day 0 and 1 week, like take more days. And so just the conclusion is that 295 nanometers fluorescence excitation imaging seems like it's able to look at visualization, to visualize epithelialization of wound closure. And it's a relatively simple system. It's wide field, it's quick, it's low cost, direct imaging method. And then when you think of adoption, when you think of the clinic, usually the best is to provide simple solutions that clinicians understand and they can just use by themselves. So the next thing for us is actually to try it in a study which is about the wounds and chronic wounds. And thank you.
I have a question.
Yes, of course.
So this UV is 300 nanometers. How much light, what is the radiance on it, and how to protect some UV action on the cells, on the living cells?
Oh, that's a fantastic question. So, so usually when I teach and when I show this to my students, I tell them, okay, I show you this UV camera. May I take a picture of you? And then some raise their hand, some doubt it. Why? Because it's UV, right? So we know that UV is good and is bad. So it's good because it's in the sun, so we can't escape it. So there are 3 types of UV: it's UVA, UVB, and UVC. UVC is the most energetic and is the one that causes mutations and it's very harmful. This is UVB, is less energetic. And actually, there are many lamps and lasers in the clinic which use UVB to treat, like excimer lasers, to treat psoriasis. And the specific numbers of the radiation, I don't have them, but it's a flash. So it says much less, which is what is called the maximum permissible exposure. And that's the number that the US used to regulate safety. So, so in order to get to this patient, we had to clear the IRB, and then we had to do provide all the safety of our camera. But the bottom line is that this camera will give you less UV than the one you would get if you walk from here to University Crossing. So it's very little irradiation.
I have another question.
Wonderful.
So it's very short wavelength. So if you're dealing with chronic wounds or something, if you have a real wound, I'm sure you'll get the signal. You'll have enough signal. It will not be.
So short wavelength, I think what you mean is like the penetration depth, right?
Yeah.
So yeah, so there's the good and the bad of the penetration depth. So the good is because it's very shallow. We know it's from the surface, and keratinocytes live there. So it has to come from keratinocytes. And then we don't know. And that's why we want to go to the clinic, because so far we have tried with what these are called like clean wounds. So clean wounds, which again, the clinician scrapes and prepares and so on. And my guess, if I have to guess, is that this will help some wounds, but not all wounds. So, but yes, blood it's an issue, absolutely.
Maybe somebody from Zoom audience, any questions?
Yes, does anyone on Zoom have any questions?
Meanwhile, I have a question. Because you work with the tail of the mice or rats or whatever, and the tail, there is a lot of collagen also there. Can you differentiate between them? So just from the experiments, because you scrap it down to the collagen layer.
Yes, you're absolutely correct. And that's what you see in day 0. In day 0, the signal is tryptophan from the collagen. And I didn't talk about this, but there is another wavelength which is sensitive to collagen and not proliferation. So the question is if we could use the other wavelength to just subtract them and tell them apart. But you wouldn't see this in humans because next to the skin in humans is the fat tissue. But yes, this is very sensitive. It's not specific. You can find tryptophan in any part of your body, the eye, the cornea, there's tryptophan.
Do you confirm it by spectroscopy?
Spectroscopy, yes. So yes, you could do a spectroscopy and a few wavelengths, yes.
Did it or you didn't?
Oh no, we did. I'm yes. So actually, So I'm just giving you the 10-minute version of this.
Yeah, yeah.
But we did a spectroscopy on both the tail and the back and imaging. And then we have more wavelengths, and then we can see the same thing, the peaks going down. We did excitation emission maps of fluorescence.